Well, good afternoon. Nice to be here in Manchester and look forward. Unfortunately, I can only be with you for a very short time, but it's all quality time. So, I'd like to thank, sorry, is that working? Yeah, yeah. I'd like to thank the Vascular Society for asking me to give this talk in my role as chairman of CHORUS, the Confidential Reporting Systems in Surgery. And over the next 15 minutes or so, I'd like to give you some examples of vascular incidents that have been reported to CHORUS. We will look at the scale of the problem in terms of patient safety, and I'll tell you a bit about CHORUS, what it does, why it exists, and its role in patient safety. Now, vials. And here's a true story. A senior consultant vascular surgeon undertook a carotid endarterectomy. Prior to clamping the carotid vessels, he asked the anaesthetist to administer 5,000 units of heparin systemically. On completion of the operation, there was significant generalized bleeding which took a long time to control, and the patient required a transfusion. It transpired that the anaesthetist thought they had administered heparin in a dose of 5 mils of 1,000 units per mil, when in fact the ampule from which they had drawn up the heparin contained 5,000 units. And they administered a total of 25,000 units of heparin, the dose for full anticoagulation. The two ampules had been kept next to each other in the same cupboard in the anesthetic room. We've heard this time and time again. And this is clearly an example of system error, and all ampules should be checked and carefully, very carefully prior to drug administration. The next slide tells his own story, doesn't it? In this second case, a patient was listed for an above-knee amputation for critical ischemia. The case had already been cancelled twice and was eventually placed on a pooled list. Although the notes mentioned that the patient had previously had a hip replacement, this was not communicated to the operating team, and X-rays were not checked prior to surgery. There was some embarrassment, as you can imagine, when it came to dividing the femur, and this great long stem of a prosthesis was encountered because it's very difficult to cut these things up, and specialist tools had to be acquired to get through the prosthesis. Another example of poor communication. The next one, CHORUS encountered 2 reports of cases in which deep cervical local anesthetic blocks were being administered for carotid endarterectomy. In each case, the patient suddenly became profoundly obtunded, and it was only rapid action on the part of the anaesthetist on each occasion in bagging and ventilating the patient that prevented an adverse outcome. It transpired that on one occasion, the dose of local anesthetic had been administered directly into the vertebral artery, and on the other occasion into the internal carotid artery, effectively giving the patient a general anesthetic. In each case, the patient was returned to the ward and uneventful procedures were carried out later. The results were published in the Vascular Surgery newsletter, and deep cervical blocks are now generally avoided. Next one is rather amusing for a colorectal surgeon, as I used to be. Tunneling a graft subcutaneously is frequently performed in vascular surgery, but surgeons shouldn't become blasé about the potential risks. CHORUS has received reports of cross-femoral grafts being tunneled through the bladder and axillar bifem grafts being tunneled through the chest and abdomen. This slide of an aorto bifemoral graft which has been inadvertently tunneled through the sigmoid colon, a bit of a shocking sight for the surgeon who had to carry out a colonoscopy. Now, while these are isolated incidents related to vascular practice, what is the scale of the problem? Helen Hogan, writing with my colleague who sadly can't be here, but you'll hear from him later, Lord Darcy, in a study of 3,600 patients in 2015, noted that 3.6% of deaths were felt to have been avoidable, with treatment costs rising in adverse incidents in hospital to around £1 billion. In another surrogate marker of potential error, in 2018-19, NHS resolutions litigation costs were £2.4 billion, approximately 2% of the NHS budget. And a further 83.4 billion has been set aside for future liability claims. I mean, it's just mind-boggling. And this is one of the most substantial UK public sector liabilities, second only to the nuclear decommissioning. So, never events. They're probably inappropriate to use that name, never events, but sadly they occur. However, we can give an indication of the extent of they do give an indication of the extent of adverse events. And in 2019, on this list of never events, the three most frequently occurring were, you guessed it, surgical. 435 of these never events in 2019-20 involve wrong site surgery, wrong implant or prosthesis, and retained products. That makes up 83% of the total. Well, we had to come to this slide. You've all seen it. It's pretty familiar. You'd be disappointed if I didn't talk about James Reeson and his Swiss cheese model. And a study by the Clinical Human Factors Group in 2011, looking at never events, found that various contributory factors, which are listed on the slide, all come together. And when they do, then you've got this arrow going through the holes. All incidents listed on the screen were part of the contributory factors for causing an adverse event. Then, if you remember, to err is human, to cover up is unforgivable, to fail to learn is inexcusable. Liam Donaldson's famous statement, which he made. And if we are to learn from adverse incidents of surgery, we need firstly to report the incidents, and secondly to disseminate this information in a blame-free manner. And that's the sort of thing that we try and do at Chorus by ensuring that the information we get is confidential. So, learning from adverse events. Surgeons have always talked to each other about their near misses and mistakes. Often they happen in meetings like this or in the bar afterwards. The problem is that this shared learning experience has not been systematic and has not been extended to the surgical community in general. Useful and non-judgmental feedback is poor or non-existent, and patient benefit has been erratic, to say the least. Now, three of the original members of Chorus were all pilots, and that probably helped in this situation. And we did a lot of our early learning through the Air Accident Investigation branch. We do know, however, that establishing confidential reporting in aviation, that people will report it straight away, and they did, and the airline industry has benefited hugely from the feedback that they get. And learning from others can reduce errors and may help to change systems. When Chorus was initially set up, we sought the help and advice of the Civil Aviation Authority, and in particular, Peter Tate, who was the chief executive at the time. He's now currently a member of the Chorus board and still a member of the Air Accident Investigation branch. Chorus was originally set up under the auspices of the Association of Surgeons in 2006, but became an independent charity inaugurated by Sir Bruce Keogh at the House of Lords in 2010, the year I took my seat. It's an independent charity run by surgeons for surgical teams, publishes reports of adverse incidents and near misses which are directly related to surgical practice, and aims to educate and enhance surgical safety, and ultimately to promote a no-blame culture. Because that's what basically holds a lot of people back, is the fear that they will be blamed. It is independent of other regulatory bodies and focuses on real and potential errors in surgical practice. It has an easy reporting process, both online and by hard copy, and it is completely confidential. We get credible expert feedback provided by a pan-specialty advisory panel consisting of members from all the surgical specialties. And you can find out more by looking at our website, www.chorus.org.uk. Now, how does the organisation work? Well, actually, it wouldn't work if Frank Smith wasn't around to be the programme director. And the whole process is pretty straightforward because of Frank. But essentially, reports come in, They're analysed, scrutinised, looked at, and then we produce a report. The reporter who provided is himself or herself provided with feedback, and then the original report is destroyed, and everything is kept as confidential as possible. Contributors are provided with a certificate. We all like certificates, don't we? And trainees have often found these useful, including these in their ARCP portfolios, or as evidence of national selection. And more senior doctors find it useful for appraisal or revalidation. And we've published extensively in some of the publications here: Annals of the Royal College of Surgeons of England, Surgeons' News of Edinburgh College, Glasgow College Journal, and we're also published in the Journal of the Association of Surgeons and in specialty newsletters. And during COVID, we ventured into online educational webinars independently and with the Royal College of Surgeons of Edinburgh and England. Chorus is also involved in lots of national initiatives, and we sit on the NHS England Surgical Patient Safety Expert Group. We contribute to the Never Events Task Force. We chair and chairing the Key Surgical Factors Writing Group for the National Safety Standards for Invasive Procedures. And in particular, we gave evidence to a Parliamentary Select Committee in the NHS Complaints and Failures Inquiries in 2015. And we also sit on the NCPOR Steering Group. We have useful communications and reporting links with NHS Improvement, the MHRA, and the Health Services Investigation Branch, and we've had fairly close relationships with Keith Conradi, the Chief Executive of that organisation. But particularly, we value our links with the specialty associations through the FSSA, from whose members we get large proportions of our reports. We are now in an era where governance, patient safety and clinical outcomes are critical issues. Vascular surgery is to be commended for leading as a specialty in this area, and examples of safety initiatives have included a National Vascular Registry with validated index case databases, recording of surgeons and hospitals' outcome data, development of quality improvement frameworks, such as those for abdominal aortic aneurysm, carotid surgery, and lower limb ischemia. And of course, don't forget PROMS, which has been the bedrock of all of this. In more general initiatives, NHS Improvement has recognised the scale of the problem and in 2019 introduced a patient safety strategy, which is now updated every year. Key aspects of that strategy have been have been the introduction of new safety metrics, and these are listed here, and the replacement of the National Reporting and Learning System, which was not really fit for purpose, developing new digital reporting technologies with which Chorus will interact, and the introduction of new incident response frameworks of medical examiners, a patient safety syllabus, and a new patient safety alert system. But key to the introduction of the NHS safety strategy, in addition to the obvious benefits to patients, are savings to the NHS. Better incident reporting and responses, better education, and focused improvement programs. The overall savings is in excess of 900 lives by 2024. That's important. But there's also a huge saving in costs in the order of 98.5 million is the expected figure. It's also reassuring to see joint education initiatives between the Academy of Medical Royal Colleges and the Health Education England, with the introduction of defined modules of patient safety curriculum, which will help focus the minds of both fully qualified doctors and trainees on patient safety. Confidential reporting in surgery is a mandatory reporting process, and it promotes an atmosphere of openness and discussion which we need, facilitates the categorization of adverse events, warns of potential hazards and pitfalls, and contributes to surgical education and patient safety. President, ladies and gentlemen, I hope I've given you a brief overview of the concerns we have about surgical safety and the ways in which Chorus, in his own way, is working with surgeons and surgical teams to improve and inform them of the potential risks they face in their everyday practice. I'm grateful to the various charities that have supported us over the years, and I'd like to acknowledge their contribution so far and to date, and I hope more will come forward. Thank you.
I'd like to thank Lord Ribeiro for an excellent talk that spans so many different areas and is quite frightening in terms of the costs that he's highlighted to us. It now gives me great pleasure to introduce Professor the Lord Darcy of Denham. Most will remember him as the Health Minister who produced the report on high quality care. He's a co-director of Global Health at Imperial College. He's a non-executive director of the NHS England and co-director of the NHS Digital Academy, just to list a few of his achievements. Unfortunately, he's not able to be here in person this afternoon, but we have a recorded presentation from him, and he's hoping to join us for the panel discussion at the end.
Hello, Chair, distinguished guests, ladies and gentlemen. May I firstly start by thanking the Vascular Society to make this contribution to your annual meeting, and also to apologize for not being with you in person. For all sorts of reasons, I couldn't make it to Manchester because of a previous commitment. Let me also say and acknowledge the friendship and the leadership of Mike Jenkins, your current president. I've known Mike for many years, working together at Imperial. Most of our long chats usually happen in the car park at Mary's, where most of the surgical politics is done with a small p. And my admiration, beside his vascular skills, the thing that really I developed a rapport with Mike on, is his love of cars and his advice. He's sort of the Lewis Hamilton of Imperial College Trust. The title of my talk is Technology and its Impact on the Future Direction of Surgery. I have been privileged to work at Imperial for the last 20 years or so. I first joined Imperial as an NHS surgeon and then subsequently moved to the dark side, in other words, the university. It's interesting, you know, I always considered myself as the commie chef rather than a fully trained chef in academic surgery. And it was an interesting finding at the time at Imperial when it was going through an interesting phase, and that was the merger of the medical school with the traditional college, which was the Imperial College of Science and Technology. And that interaction between science, technology, and medicine really is when I was appointed as the chair there. And I'm going to share with you some of our own work and the privilege of working with some amazing engineers and scientists, but also try to predict what the future may look like. But before we talk about future, it's always worth talking about the past and where and how surgery came to where it is today. And I think you have to acknowledge some of the visionaries and pioneers of modern surgery as we know it today. And that's for about the last century or so. Firstly, the discovery of anesthesia. And this is Morton at the MGH with the first patient undergoing a general anesthetic, without which I have no doubt a lot of our complex surgery wouldn't have happened today without his contribution. Virchow, a pathologist rather than a surgeon, and without his work, we wouldn't have known what is the tissue or the disease that we are removing. And obviously, the master of all surgeons, and this is Billroth in Vienna, as you can see, with the master surgeon, with the wonderful operating theatre, which still exists, by the way, and I'm sure a lot of you have visited Billroth's operating lecture theatre. And you can see many of the students looking at some of the unique skills. And I think it's important also to acknowledge that many of the instruments that Billroth designed are still with us today. And finally, our own, and that's Lister in King's, who really, his biggest contribution was the introduction of aseptic techniques into the surgical arena. And what's interesting about these four guys is they were working in different countries. They were very disparate. They really weren't mates or friends. They didn't actually have societies that met together to discuss their findings. But it was the convergence of their unique contributions that made, or at least led to the birth of modern surgery as we know it today. Although many things have changed in surgery, as we know, this is the 1700s, a surgeon who is essentially trying to do a mastectomy. Surgery at the time was described as a savage, or a surgeon was described as a savage with a knife. And this picture is a clear illustration of that. Since then, when it comes to breast cancer, we have neoadjuvant radiochemotherapy, preoperative imaging, anesthetics, perioperative care have really made surgery much safer, less painful, and from an oncological perspective, it has improved. The incision has been reduced in size as well from that very large brutal incisions that we remember as trainees. But despite all of this, the modern surgeon still bases his or her intraoperative decision-making while doing a wide local excision, not on biological data, but actual fact on the same sets of information that the surgeon in the 1700s was working on, which is palpation of the tumor itself. That is why, if you look at the NHS data, which is what we call the modern oncological surgeon, and this data was captured about a year or 18 months ago, looking at the reoperation rates in wide local excisions versus the number of primary breast conservation surgery. And you can clearly see nearly 25% or even a third of the patients who were undergoing a wide local excision had to have a reoperation because of a positive margin. Even if you look at the numbers of cases done in certain institutions, and you can see variations by a number of different NHS organizations, each green dot is an NHS organization. There is also a variation based on volume between these different organizations, which is not different than what you have always preached in vascular surgery, that vascular surgery needs to be centralized. So back to the story of Imperial, I think it was clear to me at the time, now I was a failed biologist, by the way, the only way we're really going to transform surgery, which is very technical, very mechanical, was really to look at some of the platforms of science, whether that is chemistry, physics, engineering, computer science, certainly in the last decade, mathematics in terms of prediction. And that's really what has been the, if you like, platform technologies, which is a convergence of one or two or even more in terms of discovery and innovation. In other words, creating value, whether that is a surgical value, which leads to a health value, and in some instances, some commercial value, as you will see in some of the examples that I will share with you. So we'll move on to the next slide. Now, I'm going to cover a number of different themes based on these platform technologies. Firstly, genomics, another omics revolution, and what is its role in surgical practice. Some of the devices, imaging, robotics, and its conversion of mechanical engineering, data manipulation, mathematics and modeling, materials and microfabrication in terms of design of new instruments and tools, information technology underpinned with artificial intelligence, and we've seen the impact of that in the last decade or so, or navigation, which is a very important cue in surgical practice, and also other forms of imaging like biophotonics and spectroscopy. So moving on into another example to think, or another background to share with you, which is the impact interaction of the human genome with the surgical environment, something that we haven't really given much thought and time previously. And this work was done collaboratively with Jeremy Nicholson, who's no longer with us, he's gone to Australia, who is a chemical engineer, and who, with a number of our senior lecturers and PhD students, this work was mostly done with James Kinross, where if you really look at the genetic revolution, what genetic revolution has taught us that our genes are not the blueprint for life. We thought it was. Biology is much more complex than what we thought it is in terms of the contribution of surgical outcomes. And that is mostly based on the interaction of the human health. It's all about the interaction with the environment and the environment that we live in. Let's start with our own environment, which is the human species, as we all know, has about 25,000 genomes. But as humans, we also lived symbiotically with about 100 trillion bacteria, weighing for about 1 kilogram in weight, and we call this the microbiome. The 100 trillion bacteria have 10 million genes, what we have measured so far, and I'm sure there is more. So thus, 3% of our genes are the human genes, but we live in harmony and symbiosis with a significantly greater number of genes, which is within the microbiome, which is the 100 trillion genes. So surgery or surgical trauma is one of these intrusive attack of that symbiotic relationship between our own genome and the microbiome that we live with. And that usually is amplified by a number of other interventions, whether it's nutrition, antibiotics, or all sorts of other drugs, including anesthetic drugs, contamination, whether that is a surgical contamination, and other biological fluids and agents, whether it's a transfusion or even a leak from an anastomosis. And that disharmony between our own genome and the microbiome that we live with is really, in many ways, is the area that we try to explore. What is that contribution to the recovery and the well-being of a surgical patient? So these dynamic changes are important. And our next study, and this was a more of a longitudinal phenotyping study of the whole surgical pathway of care, again, led by James, working under the auspices of Jeremy Nicholson. This was published in Nature nearly 8 or 9 years ago, starting with the preoperative measurements in terms of the whole phenotyping of that individual, whether stools, blood, urine, and again, looking at the whole pathways of care, whether it was out in the community, elective pathway, elective surgical pathway, an acute or an emergency admission. And you can see the huge amount of information that we've gathered preoperatively, at the diagnostic phase, at the intervention phase, whether that happens to be chemotherapy or a surgical, post-intervention phase, and obviously at the recovery stage, including, for example, looking at death. This was a fairly longitudinal study, which took a while, and I'm just going to share with you one interesting finding. This is one of our PhD students with Zoltan Takis, who is another chemistry biology. The work started by the installation of an NMR spectroscopy or a mass spectroscopy machine in the operating theater. And this was the first operating theater that had a mass spectroscopy machine. You can see it there, plus another lab on the 10th floor we all work in for much more sophisticated analysis. And this is one spectroscopy, and we're looking at the cerebral spinal fluid. And I thought I should share this with you because these were a cohort of patients who are undergoing a thoracoabdominal aneurysm repair done by our colleagues, including Mike Jenkins on the St. Mary's site. And what's interesting to look at here is the longitudinal metabolic phenotyping of the CSF in patients. And you can see that each of these spikes, by the way, corresponds to different metabolite, and we are able to study as many as hundreds of these metabolic signatures, one at a time, and looking what a normal trajectory. By this work, we were able to predict normal trajectory of these metabolites versus the outcomes of that patient. And you can clearly see the correlation based on their multivariate trajectory of CSF and looking at the outcomes over the post-operative recovery from that surgical procedure. So if you like, a preemptive diagnostics by looking at CSF fluid in the post-operative period could give you some predictions of trends of ischemia or trends that may have an impact on the recovery of that patient. The next piece I'd like to share with you, which was another transformational technology working mostly with Zoltan Takis, which is this concept of the eye knife, which is the plume that comes out of the diathermy device. And the challenge for us there was, is there anything in the plume that we can measure to tell the surgeon intraoperatively whether they're actually cutting into your tumor? And again, back to the wide local excision of breast cancer, could we have another more diagnostics test with a higher specificity and sensitivity that could tell the surgeon intraoperatively? And I'm going to show you a small little video demonstrating this. It's mostly an animation, actually, in fact, and then I'm going to share with you the trial itself. This is an animation. Instead of a breast, we're looking at an excision of a solitary metastatic lesion in the liver. And what we've done, which is the diathermy machine, we've included suction tubing that actually sucks the plume and the smoke into a tube that goes straight into the mass spectroscopy into the operating theater. And as you can see here, the plume has obviously a number of metabolites and particles. They're going into the suction tube, straight into the mass spectroscopy, which has actually a fairly large database of what is tumor, what is not, and displaying that to the surgeon in a clear red blob, meaning that they're cutting into a tumor, versus a green blob, meaning they're cutting into a normal tissue. And that is being transformed into a device now. And that device is essentially, this is another display of a breast cancer case being done live, as you can clearly see here. And you can see as the surgeon is cutting, the plume is giving him the green or amber or red signs in terms of where they are in terms of the excision of that tumor. And this is turned into a red. So that is the spectral analysis. And you're looking at a number of different benign and malignant tumors. This is a fibroadenoma, and you can see the spectral, the actual metabolic signature is very different than the invasive ductal carcinoma or a normal breast cancer. And then followed by a histopathological report, obviously. And you can see here that we can actually validate the different components of what is normal, what is cancerous, what is a fibroadenoma, what is a normal breast tissue. So the initial validation, both in the lab and some early phase 1 trial, has led us subsequent to that to run a fairly large randomized control trial. And this is down left, one of our senior lecturers at Imperial, who's leading this trial. And again, to see whether the eye knife will reduce the positive margin rates when it comes to wide local excision of breast cancer. Back to the 1700 surgical picture that I demonstrated to you earlier. Moving on to other utility of such technology, and again, metabolic signatures, is sepsis. And sepsis is becoming a major issue, whether that is in non-surgical patients, but also in surgical patients. But the ability to be able to take a metabolic signature of the bacteria, either to diagnose it, but more importantly, to demonstrate where there is antimicrobial resistance using metabolic signature, was another challenge we looked at. And this is a schematic approach where a tiny sample is done of the tumor, of the wound edge, in this case, with 2 electrodes, again, no different than the old-fashioned diathermy we used in open surgery, and whether that could be from the wound itself, or it could be from a culture agar, as you can see here, back to the mass spectroscopy machine to give you some form of a reading, whether you have infection or not, and then potentially looking at the metabolic signature of that bacteria, whether they are resistant to the antibiotic that the patient might be on. So the other area of work, I think, worth looking at, this is the real-time intraoperative microbiology of the wound microbiome, which is done mostly in debridement of wounds. And this was published again in 2016. And since then, we do have such a device now in the microbiology lab. We're not commonly using it intraoperatively, certainly not in clean cases, but if they're in debridement going back, it's not uncommon that a surgeon will be using these to ensure that there's a complete clearance, or at least the debridement is adequate enough in terms of the sterility of the wound, if that is at all possible. One other area which was fascinating, certainly in those with oncological surgery, is this whole phenomena of tumor heterogeneity, which we understand much more now than we did in the past. And I think its relevance mostly in metastatic disease, and in this case, which is the tumor heterogeneity in kidney and renal cancer, and in some cases of metastatic renal cancer. And this is a different type of a technology, which is what we call desorption electrospray ionization, a technology called DESI. And the DESI platform, again, was invented by Zoltan Tekis, which essentially requires a minimal sample preparation intraoperatively, in other words, in the operating theater. So instead of having an in situ biopsy and a pathologist coming to give you a frozen section at the time of surgery, and we all know the pain of that, is there a chance we can use DESI once their tissue is prepared and use mass spectroscopy to study the chemistry of the tissue samples, analyze of the analytics, metabolic analytics, rather than the genes, to really provide us with some form of a metabolic signature, whether the actual frozen section has a tumor sample or not. And then the potential also, by the way, to reconstruct this. And in this example here, we've taken all sorts of slices of the tumor itself. In this case, being a colorectal cancer, there are 51 sections, slices, as you can see, and we have reconstructed in 3D, again, to display to the pathologist, the surgical pathologist, whether actual fact it's essentially a better look at a tumor margin and the staging of that tumor post-operatively done under the auspices of the pathology department. Moving on to the next area of convergence, which is mostly in devices and imaging, and I'm going to share with you some of the work in robotics. And I know Mike and many of the vascular surgeons in the department have been actively involved in this. And these are either platforms to improve access, platforms to improve the characterization, or even targeted therapy. I'm going to share with you some access in terms of micro-robotics or nano catheters, which could go into third, fourth, fifth generation vessels or bronchial tree, for example, in areas where it would have been impossible to gain access to. Could we actually have a tissue characterization using these nano fiber catheters? And finally, could we deliver a targeted therapy through? Let me start with robotics first. This is nothing new here. This is the Davinci Robot, which started, certainly the program started at Mary's in the year 2000, nearly 21 years ago. And then since then, with great pleasure and delight, see there are a large number of centers across the country doing robotic surgery. They're mostly in prostate cancer, but obviously there are many other utility now in areas of colorectal cancer, but also in gynecology. So the utility has increased. Some of the early work in renal cancer that we did, which is augmentation of images. Sorry, let me come back and show this video again. Augmentation of images. And this is a preoperative MRI reconstructed. We reconstructed a virtual kidney. We actually registered the virtual image on top of the kidney, because in this type of surgery, you're not going to see where that small tumor in the upper pole of the kidney is. But actually being able to augment the virtual image on top of the anatomical visualization of the organ by the surgeon allows you to ensure that you're actually doing a partial nephrectomy with clear margins. In other words, guiding the surgeon intraoperatively. And this has become more or less a routine use of this type of excision in cancer. The potential of more precision, this is the TEMS device, which is the transanal endoscopic microsurgery, which was funded by the Wellcome Trust, which was allowing us now to go and do a full thickness excision of rectal lesions transrectally, using, again, a robotic interface, but more importantly, with some instrumentation of 3 degrees of angle of movement inside a fairly small cavity, which is the rectum. This is another technology by George Melonis, one of our lecturers, who worked with me and Guangzongs in the past, looking at the Cyclopes. Essentially, the Cyclopes is an endoscope, a colonoscopy device. We've attached a flexible attachment to it, as you can see in this diagram here. And then as you go inside the lumen of the colon, you can inflate this balloon to create space without rupturing the colon itself, as demonstrated here. And once you create that space, you actually have 2 instruments going through. in addition to the flexible scope, by the way, which is giving you the image and the picture you're looking at. And these instruments have 6-degree freedom of movement, which allows you to do a full thickness excision of a polyp, not just within the rectum, but up to the sigmoid colon. And even, by the way, in a prepared bowel, do a full thickness excision and close the defect without the requirement of a colostomy. Back to the mass spectroscopy, and certainly the what I demonstrated earlier, which is taking the metabolic signature of the breast cancer. Could we, for example, give that same diagnostic tool to an endoscopist, a colonoscopy, who's removing a polyp, to give them at least a rough idea whether that polyp is benign polyp or a malignant polyp, is another area that we're currently studying. Again, that's led by the group here, mostly Professor Golden, who is the pathologist here, with Sultan and James Kinross, and Alex, one of our PhD students. And this is the correlation, by the way, of what is normal, which is the green blobs here, what is cancer, and what is a benign adenoma. So you can actually stratify by the mass spectroscopy device, by the metabolic signature of what you're looking at, comparing benign polyps to normal tissue versus a cancer. Moving on into the micro robotics and micro catheters, and you can clearly see some of the diameter of these, 5 millimeters, with a hollow channel that allows biopsy or targeted therapy. This is a wonderful picture demonstrating the actual biopsy forceps here. And just to give you a relevance in terms of size, what we're trying to capture here, this is a hair follicle. So you can see the size of the catheter in terms of pushing it down to, again, up to 6 generation branches of the vascular tree, or the bronchus in this case. And the ability then also to deliver targeted therapy to these areas is also very exciting for the future. Other areas is what we call implantable senses, and that's mostly my own field of rectal cancer. We have sensors, wearable sensors has become part of all of our life, but the challenge here was, could we actually have an implantable sensors in a rectal tumor of a patient receiving neoadjuvant radiochemotherapy? And it's mostly the radiotherapy that we're looking at. And we know, for example, in rectal cancer, there is a 10% complete remission of the tumor or destruction of the tumor. And we know that because once we go in and do an anterior resection, most of these specimens do not have cancer in them. So the ability to predict that by having a sensor that looks at certain biomarkers, whether that's tissue oxygenation, lactate, or pH, but even more sophisticated biomarkers, is one of the platforms that we're looking at. And by exhausting a number of different technologies, the one we've settled to in clinical phase 1 trials has been the fishhook, because one of the difficulties we had with the rectal tumor sensing was, in actual fact, as feces passes through, we're losing a number of these sensors. So moving on into next, which is real and the role of data in terms of delivery and improvement of delivery of surgical practice, but also in delivery of healthcare as a whole, whether that comes to automation, whether in getting patients more involved in their care, real-time management of assets, and I've demonstrated you some platform assets earlier. How do we reduce variation, connectivity, and data sharing, which has become extremely important. And I'm going to go straight into one area, which is the area of patient safety. And just to share with you some of the work, this is one slide covers a continuum of work, which took about 5 to 7 years. One of which was an epidemiological study looking at the deteriorating patient in a hospital setting on the left-hand side, and looking at a number of different provider organizations across London. We, actual fact, even within a hospital setting, we failed to detect nearly 1 in 5 hospital patients who demonstrate signs of clinical deterioration. And that's a serious challenge. And you can appreciate all of us as surgeons being at home, sleep, day 2, post-op, someone is deteriorating and no one finds out about it until the next morning on a routine background. So the idea here is, how do we close that gap? How could we work to identify these deteriorating patients in a much more timely fashion. Helix is a center at Imperial, which is a joint center with the Royal College of Art. So I employ 8 designers in the institute. And these designers, working with engineers and clinicians, they're mostly clinical PhDs and some postdocs, developed something called the Hark device, which is a digital application, which actually captures from the 37 different systems that we have in Imperial, which have never been integrated. So we could capture the physiological data, the biological data, in other words, hematological, urea electrolytes, and all sorts of data to give some risk score on a deteriorating patient. We got stuck with that, sadly, because one of the issues was how do we integrate the data sets from these very large number of databases. Then eventually DeepMind, which was independent at the time, approached us because they were interested in the digital lab, and DeepMind is well known in AI work, as you all know. They funded a platform that actually could combine the data sources from these 37 different systems that we have, and eventually acquired this app, which was called, at the time, it was called Hark, which was really led by Dominic King, one of our lecturers, surgical lecturers. And sadly, we lost Dominic with it. He went to work for DeepMind. And I think another amazing vascular surgeon, Alan, was the other lecturer with us who went to DeepMind and started working on this, and essentially was, implementing the big vision we had at the time is how do we really transform the health value chain and move it from a labor-driven to a technology-enabled model at the time to more digitally driven and a human-enabled one. So completely reverse the role of the technology and role of the practitioner involved in the care of that patient. This was Hark at the time, and most of its work was really trying to be moving from what we're very good at, by the way, many descriptive analytics, and the Vascular Society has had many papers in the past, into more predictive analytics, which is to anticipate what will happen. But our big prize was the more prescriptive. In other words, how could we provide recommendations on what to do to achieve the goals? So predictive and prescriptive was really the combination of the two that what brought DeepMind and AI into another research themes in the department. And AI is in long way to go when it comes to healthcare. Just look at the percentage change of trajectory of AI on the vertical axis versus which platforms it's had the biggest impact. As we all know, in financial services, high-tech telecommunication, AI is playing a major role. There's a significant growth in health. And I'm going to share with you some of the work that we had the privilege of doing with DeepMind. And DeepMind, where it became famous, as you probably know, with the AlphaGo, where the machine for the first time beat the best AlphaGo chess player. And AlphaGo, by the way, Go is a very different chess game played by Chinese mostly, and Korea as well. And that was a phenomenal moment in history of science where a machine could beat a human at chess. So following that, we started to work on mammography, and we wanted to see whether we can develop a predictive algorithm working with DeepMind that could actually optimize screening, reporting, and accuracy, or at least the sensitivity and specificity of mammography screening for breast cancer. Our first task was we needed to get images, although we do have many images, but what we really, if you're really going to get involved in AI training, you really need annotated images to have value. And again, I'm going to reinforce this message subsequently because imaging is fairly common in vascular surgery. An image is not worth anything without the annotation by the expert. So we managed to find 8,000 training mammograms, believe it or not, which were available through Cancer Research UK, a company called Optimum, which was a spin-off, which was really the, if you like, the cohort that we used for the training, followed by another 30,000 mammograms from the NHS. And that's really what started this program between Imperial, Cancer Research UK, Optimum, and the Royal Surrey County Hospital on behalf of the NHS screening program and Public Health England. And what we're trying to do is really get more supervised learning, which is the classical ML techniques, where algorithm is trained to recognize a particular feature on a row of data sets. And this is really what we use, and what we wanted to find if there is a lesion there, whether it's cancerous or non-cancerous. And finally, the major study, which was the international study that we did, which was published in Nature. In actual fact, it was published in January 2020, was the seminal work. And I'm going to share with you some of the data from that. And I think, being vascular surgeons, I just thought I should give you some rough idea. Out of every 100 women screened, by the way, 4 of them are usually picked up by the screening program as have an abnormality on their mammogram. And I think that the critical bit here is that out of the 4, as we all know, only 1 has diagnosis of cancer and 3 have a normal result. And I think the big challenge usually is, how do you deal with the 3 who have a normal results? Because a significant number of them end up having surgery, and a lot of the surgery could be quite mutilating. In actual fact, the disadvantages are not just overdiagnosis, anxiety, unnecessary interventions, and in many cases, false confidence. So what we wanted to do is to see how could we improve globally the sensitivity of mammography even greater. And this is the deep learning model that was developed by DeepMind based on the data sets that were shared with them. And again, if you really look at scientists, some of the best data scientists in this country are all working in DeepMind, which is a phenomenal. And then what we wanted to do was to do an evaluation, compare the algorithm reading a mammogram versus a clinician. And we did that in 2 different countries, in the UK and in the US. In the UK, we had 120,000 mammograms, by the way, and these were done retrospectively. In UK, as you know, we do 1 screening program with a time frame of 3 years. In the US, they do it every year or every 2 years. We picked up the mammograms from 2012 to 2015. And all of them had biopsies from Guildford, Cambridge, and St. George's, and then compare those to more than 20,000 mammograms in the US, a very different way, as you can see, in the way they manage their mammography. And the other interesting difference between the UK and US, in the UK, is that you get 2 radiologists to report a mammogram versus the US, which is 1. So looking at what we call the ROC curve, which is the receiver operated characteristics, which is really what we use for diagnostics, you can see in the UK, compared to the first reader, the AI system demonstrated a significant improvement, 1.2% of superiority, and significant sensitivity as well, improvement about 2.7%. Now, if you compare that to the second reader, the AI system essentially showed no inferiority. In other words, it's equal. So if we compare the algorithm to 1 reader in the UK, it did better. If we compare it to 2 readers, it did as well. If you look at the US data, which has 1 reader, as you can clearly see, the improvement was dramatically better. In actual fact, the significant specificity improvement was about 5.7%, and the sensitivity was even higher, about 9.4%. So this is the first time where we have an algorithm. Certainly in the UK, we're implementing this now within the number of centres within the NHS on the back of NHS-X funding. We're implementing it essentially just to see whether we can substitute the second reader. So essentially, we need half the workforce in breast cancer screening programs. This is the analysis of the other imaging modalities. This is in cardiology. An interesting paper looking at the analysis of ECGs by AI and comparing them with the interpretation by physicians. And again, a wonderful aiding technology. And I think most ECG machines now will have an AI algorithm that actually will give you the report at the same time. And as the data clearly demonstrate the potential advantage of it, and obviously in certain areas where human reader is still required, but I'm sure with time that will change. AIs also have a significant role to play in plaque composition. evaluating the percentage of heart that is ischemic, looking at patterns of scarring post-myocardial infarction. So AI in cardiology or cardiovascular disease will have a significant role to play, and also the sensitivity in terms of predicting artificial atrial fibrillation in those who are wearing the 24-hour tape, which is something that we always struggled with when it came to cardiology. Another area which I have had the privilege of chairing, which is the preemptive health and health security. This is flagship pioneering in the US, who actually created Moderna. And this is an unbelievable piece of work, which is looking with AI or machine learning, a device called Octavia, looking at every possible mutation that COVID-19 could possibly have. Based on the variant that we've had so far, we can actually sequence potentially 10 to the power of 50, which is greater than any atom available to us. While we're doing this, we're trying to predict what would be the next variant. So the Indian variant will be the Delta. And the question is, could you predict the cousin of Delta, the first and second cousin of Delta? This is Delta itself. You can actually see its protection, or at least its escape strategy against the current vaccines. And once you go to the red zone, this will be the first cousin, which is essentially doesn't have a number, as you can see. Similarly with the California, which is a hybrid variant, and the New York variant, which is another variant we haven't seen in the UK. While we're doing this, we really want to generate the high-risk neighbors, try to validate virtual variants of concern that actually may not be covered by any of the vaccine. So that's exciting, and that's another area I think we're going to have a tremendous contributions in AI in the future. Pathology as well, comparing AI model to a pathologist, AI plus a pathologist, you can see is probably the best. So I think in most diagnostic tests that require high sensitivity specificity, is most likely to be an algorithm and a human together. The impact of this is going to be huge, AI in healthcare, whether it's the cost savings, whether it's the productivity gains, and that is not displacing the human role in healthcare. That is closing the significant gap we have in workforce, by the way, certainly in this country. And in terms of the savings are astronomical, to say the least. AI does have some problem too, and I just thought I'll share this joke with you. This was an unforeseen issue of machine learning, which was experienced by the US military, as you can see, of this camouflaged tank. And I think what the machine learning task was to see whether they could identify camouflage versus non-camouflage tanks. And interestingly enough, after a number of experiments, the AI did predict, but didn't actually predict the camouflage versus non-camouflage. It actually, in fact, it predicted the weather changes, or at least the time of the day, rather than the actual camouflage of a tank. So I just thought I'll end up with a humorous piece. Coming back to what I said earlier, vascular surgery sits on tons of assets, which is the images that you have on the vascular tree. The one thing, if I could give one message through the Vascular Society, is that data is extremely valuable. If we can start prospectively now into the future, start annotating this. I mean, the dilemma I've always had with my radiology colleagues, why do you look at a digital image and give me an analog report? Why don't you put a digital report on the image itself? Because I could learn in what you're looking at. And that is a complete change we need to embrace if we're really going to have the assets to drive this into the future. Finishing off with design, and I just thought I should share this with you. This is our Helix Center, which is the pod in Mary's. If you ever pass Praed Street, you see this. These are our designers working with one of our lecturers who's a clinician, and looking at different areas of work. And I just thought you probably remember the work I did in stroke in London, the London Framework for Action, and setting up the comprehensive stroke centres in London, one of which is in Charing Cross, and there are 3 others in London. These were challenging times because reconfiguration of strokes from 32 to 6 comprehensive stroke centre wasn't easy. Although we dramatically improved stroke care, mortality is probably saving 200 lives a year. And by the way, this became a Harvard Business School case study, which is something we're all very proud of from an NHS perspective, that change could happen within the NHS. what we wanted to do, how do we improve rehab post-stroke? And this became a critical issue, by the way, during COVID, because there was no rehab for patients having stroke. And this is an application of, this is the case for change. As you can see, the number of people having stroke worldwide, strokes per year in the UK is 1 in every 3.5 minutes, and the whole expenditure of stroke. So we wanted to design the possibility of a digital application that will allow, with an iPhone, with an iWatch, as you can see here, or even it doesn't have to be an Apple Watch, any digital watch would do, is the combination of a digital application and a watch to actually train the individual with rehab techniques at home, in their home environment. And this is what we used during COVID to validate our study. And it was again, simple technologies like this will have a huge impact, not to mention intermittent claudication, an improvement that could be behavioral from a patient perspective. So on that note, I'm just going to finish off and summarize what I've just said. We're doing a lot of discovery research, which is absolutely critical for surgery. The translation element is even more important thanks to the BRC and many of the BRC centers who are led by surgeons, including vascular surgeons around the country, and the funding agencies who actually started in the last decade or so, at least, funding surgical research, which is quite refreshing. And most of these things, actually, in fact, I never really do the work. It's these clever guys, whether computational system medicine or the Hamlin Center for Robotics, and it's the combination of convergence people, bringing clinicians to understand the jargon of engineers, bringing engineers to understand the jargon of clinicians, is really what makes things move on. On that note, thank you again for having me with you, and I'm very grateful for the invitation. Sadly, I'm not with you, and I wish you a very good day. Thank you.
So AI is coming. Cardiologists may be safe for a little while, but perhaps not diagnostic radiologists. So there are all those juniors in the audience thinking what to go into, think on. Lord Darcy, there is a unabridged 45-minute version of that online if anyone wants to dig deeper and see what he's talking about. And he hopes to join us for the panel later. Now I'd like to introduce Professor Peter Rothwell, who is Professor of Neurology in Oxford and co-founder of the Wellcome Foundation for the Prevention of Stroke and Dementia. He's going to talk about what the atherosclerotic burden is in the post-smoking era. Peter, you're very welcome.
Thank you, Michael. Thank you very much for the invitation. I've not been to this meeting for a few years as a neurologist, but I always enjoy it. So we've heard about how to reduce the burden of clinical care by reducing the mistakes we make. We've heard about how to try and improve the way we do things. So in terms of workforce planning, what's happening to the burden of disease that we have to deal with? And I think that's the main subject of this talk, particularly in what people sometimes call the post-smoking era, which I think is probably not really that accurate. My disclosures, sadly, are mostly unpaid. So what do we die of? Well, we still die mostly of, the laser pointer, yeah, of cancer or vascular disease, and of vascular disease, peripheral artery disease and other arterial diseases are a big chunk of that, along with coronary disease and stroke. So there is a big burden of disease in terms of disability and death. Smoking rates are falling dramatically, as we all know, at least in the developed world. They've peaked in the 60s, 70s, and in the UK have since been plummeting and continuing to come down. And the obvious associations like lung cancer, which is the pathology most strongly associated with smoking, is also coming down dramatically in men and beginning to come down in women as well. And so reductions in smoking are impacting on disease. Other cancers will come down as well. Other smoking-related cancers, the data are less clear, but they will come down. And there are other diseases as well that are strongly related to smoking. Lung disease, emphysema, is more strongly related, in fact, than lung cancer. It's a 36-fold increase in lung cancer risk from non-smoking to heavy smoking, a 60-fold increase in risk of emphysema, but also increases in heart disease, stroke, and peripheral artery disease and aneurysms, as you all know. The effect sizes are about 10 times smaller than they are for lung cancer and lung disease, but they're still strong risk associations, and reductions in smoking will, to some extent, reduce the burden of disease. I said, though, the title I was given was the post-smoking era, and it's worth making it clear that the smoking rates are falling in the developed world, but they're not falling in the rest of the world. Smoking is increasing in China, India, and if you look at the number of smoking deaths projected worldwide, then there are 100 million in the first part of this century, and probably up to 1 billion smoking-related deaths worldwide this century. And that compares with an estimate of about 100 million in the 20th century. So we think of smoking-related disease as being a 20th century problem. In fact, we haven't even started to scratch the surface at a worldwide level. The vast majority of smoking-related deaths are yet to happen unless smoking rates fall in India, China, and other developing countries. So what do we know about the UK? And I just put this slide up to thank my colleague, Dominic Howard, who has collected a lot of the peripheral vascular disease data that I'm going to mention. And just an advert for our new centre in Oxford. Anyone who's interested in doing research in vascular disease and wants to pay Oxford house prices would be welcome to come and join us. One of the studies which Dominic's helped with, and we get a lot of data from in terms of the burden of disease, is something called the Oxford Vascular Study, which is a population-based study where we try to ascertain and assess on a daily basis all the acute vascular events in a population of about 95,000, so TIAs, strokes, coronary events, and peripheral vascular events. And this allows us to phenotype the patients well, and also to be fairly certain that we've got all the events. And I think there's still a role for that kind of hands-on clinical epidemiology, in the sense that although big data has its uses, you do still sometimes get the wrong answer from routine coding data. And these are just a couple of examples where, for example, this is the temporal trend in recent years in delirium complicating hospital admissions in Oxford, with a 6-fold increase in the rate of delirium according to coding. So the CQC should be interested in that, and it looks like a disaster. In fact, it's all coding, of course. It coincides with an educational campaign we had to increase the coding of delirium among junior doctors and to increase the accuracy of coding of delirium by the clinical coders. In fact, the rate of delirium actually fell during that period. This is another example, the risk of bleeding on antiplatelet drugs, particularly in older patients. When you do face-to-face follow-up, you find very high rates of bleeding, major bleeding on follow-up, whereas many of those are missed, particularly at older ages, by hospital coding data. So there are shortcomings of coding data. And of course, you can't dig down and really understand things like the severity of events. For example, this is the severity of bleeds in that same study, showing that the really severe life-threatening bleeds are very much more common at older ages. Now, the trials of antiplatelet drugs are all done in this age group, and clinical practice is now in this age group in terms of the patients that you see and I see. So it's important to understand that. And in fact, in terms of disability, the disabling bleeds, and most of these are GI bleeds, are pretty much confined to the older ages. So we are potentially doing harm if we're not careful to reduce the risk of GI bleeding in our vascular patients on antiplatelet drugs. And a final example of coding data getting things wrong is the weekend effect. You may remember 4 or 5 years ago, there was a standoff between the junior doctors and the government about reorganizing clinical rotas, because the government was convinced that weekend care was appalling and used stroke as the sort of poster child, where the routine data showed that stroke outcomes at weekends were much worse than stroke outcomes during the week. In fact, that's turned out not to be true, and this is one of the first studies that we did showing that in fact it's all coding error. The strokes were mainly wrongly coded in the routinely collected data studies. A lot of the acute stroke admissions during the week were routine admissions post-stroke for investigation or rehabilitation. And so that dramatically pulled down the mortality rate for admissions during the week, whereas of course that doesn't happen at weekend. So you can't always get to the truth with big data. So that's the plea for epidemiological studies with hands-on data collection. So what's happening in terms of the burden of disease? Well, this was a few years ago, looking at what had happened to stroke incidence over about 30 years in our area, from a previous study in the 80s to the early noughties. And stroke incidence had come down by about 40%. But what was interesting was that the number of strokes had actually gone up by about 30%, because of course the population had aged so much that the denominator was so much bigger at this age than it had been in the 1980s. So a 40% reduction in incidence and a 30% increase in workload. And that's one of the problems we face. And in fact, when we projected the number of strokes going forward, if incidence didn't continue to fall rapidly, then we were looking at about a 300% increase in the number of strokes over the age of 85, if we couldn't continue to reduce the age-specific incidence. The other problem we've got, I think, with the impact of things like smoking and statins is that as disease moves to the right on the age incidence curve, the risk factors that we traditionally worry about, and they're the same in coronary disease, peripheral artery disease, and stroke, become less important. So lipids and other risk factors are less strongly related to disease at older ages, which is more just a degenerative process. What risk factors do is bring the age of onset down, and so they much more strongly cause disease at younger ages, but their associations are weaker at older ages. So reducing smoking, increasing statins will have an impact, but not so much perhaps at older ages. So that's the second problem. The population's aging rapidly, and the disease we see in older people is less strongly associated with risk factors. So what's happening with peripheral vascular disease? These were some data that Dominic put together on acute aortic aneurysms. And you see the same picture you've seen elsewhere. Smoking is very important for disease at younger ages, but less important at older ages. And when you project the numbers of events going forward in the UK, then the change is really at older ages, with a big increase in the number of events over 75 and over 85. And of course, this has implications, as you know well, for your practice, but also for screening programs and how we evolve aneurysm screening in the UK. And it's the same sort of picture for peripheral artery disease, chronic limb ischemia, same sorts of risk factors, hypertension, smoking, and particularly diabetes that we'll hear about in the next talk. But again, the numbers are projected to increase despite reductions in smoking and despite control of hypertension, partly again just because of the aging of the population. The number of patients will still go up, so we still need vascular surgeons. The same for aortic dissection. The rates of aortic dissection are coming down in terms of incidence, but the number of people having dissections are still projected to rise. And that's more because of inadequate management of blood pressure than it is related to smoking and lipids. So again, the workload isn't disappearing for dissections anytime soon. Most importantly, from a stroke point of view, is atrial fibrillation. This is the age-specific incidence of AF-related stroke or systemic emboli that you see. And you can see that any increase in the number of elderly population will dramatically increase the numbers of AF-related events. And interestingly, if we compare the old study in the 1980s to our current study, then despite the fact that warfarin was invented and introduced into clinical practice for AF between the two studies, the number of AF-related strokes has actually gone up substantially, particularly at older ages, nearly doubling. And that's mainly because of underuse of anticoagulation at older ages. And I think we had 208 patients over 80, only 9% of whom were anticoagulated prior to their stroke, and nobody over the age of 90. So if you project the number of AF-related strokes as the population ages between now and 2050, then the projections are fairly frightening unless we can increase the rates of anticoagulation. So what's actually happening? Not what are the projections? Well, the incidence of stroke overall is coming down, as you can see the top line there. But the incidence of AF-related strokes sadly isn't, the bottom line, and it's still fairly flat. So that does mean the number of AF-related strokes over the age of 85 will probably quadruple over the next 2 or 3 decades unless we can get more patients anticoagulated. And it comes at an enormous cost in terms of health and social care. The other strange thing which is happening, and my laser pointer has died, so I can describe it on the slides, is that the incidence of young stroke is now starting to rise. So stroke over 55 is coming down, but young stroke is beginning to go up. And it's in contrast to MI. If you look on the right, that's under 55 MI rates versus under 55 stroke rates in men. And they're going in different directions, and it's not entirely clear why that is. Interestingly, in both men and women, it's accounted for by people in professional occupations. So it's you lot whose stroke risk is increasing rather than the more deprived end of society. And it's generalizable. If you look on the left there, you can see stroke admission rates in England, which are going up using routinely collected data, and they match what we find. And on the left there, or my right, you can see a systematic review of what's happening around the world, in the developing world, and stroke risk in young people is going up across the developed world, which is an incredibly worrying signal if you think that the diminution or the falling rates of incidence of vascular disease for the last 50 years might be now reversing in an age-specific cohort sort of way. And it might be the first signal that all the assumptions we've made about vascular disease disappearing are wrong. And it compares very, very closely to what's happening with things like colorectal cancer, which is coming down at older ages and now going up quite rapidly at younger ages. And vascular disease and colorectal cancer have just the same risk factors, so you might expect them to behave in the same way. So that's the incidence of disease. What about risk of recurrence? A lot of our disease burden now is recurrent events in secondary prevention. About 40% of all vascular events now occur in that setting rather than as a first event. And these are the most up-to-date data we've got on the risk of recurrence or vascular events after a TIA or stroke. And you can see they're quite high when you stratify by age and vascular risk factors. And that's a worry as well, because of course we can push down the event rates by giving people statins, controlling their blood pressure. But at the same time, the population we're dealing with is aging rapidly. So it's unlikely that we're going to reduce the number of recurrent events because we're up against a rapidly aging population, and age is the main predictor of recurrent events. So that's again a slight worry. What about carotid disease rather than just stroke? This was a systematic review we did a few years ago looking at the annual risk of stroke distal to an asymptomatic carotid stenosis. And we very confidently said that, well, you can see suddenly at the year 2000, the risk seems to drop. All the studies have a halving in stroke risk, and that must be due to statins. So we can stop operating on asymptomatic carotids because the prognosis is now so good with statins. And we followed that up recently, or Dominic Howard did, with an update, and you can see on the left that the annual risk of stroke has continued to fall. And that goes very nicely with a falling prevalence of smoking in these patients and a dramatically increasing use of statins. So it all makes sense. The prognosis is getting better. But in fact, it's completely wrong. And the reason it's wrong is that people didn't realize that the degree of stenosis matters a great deal in patients with asymptomatic stenosis. There's always been this strange idea that degree of stenosis matters in symptomatics, but not in asymptomatics. And that incorrect assumption has come from the clinical trials. On the bottom left there, you see C is the data from randomized controlled trials of the medical group looking at the impact of degree of stenosis. The upper two sets of bars look at cohort studies. And both in our study at the top and in other cohort studies, the risk of stroke is strongly related to the degree of stenosis in asymptomatic patients. And in fact, when you stratify the systematic review and the studies that report data by severity of stenosis, you can see that on the right there, the risk of recurrence for severe stenosis versus moderate stenosis has not changed at all. All that's changed is that the proportion of patients with moderate stenosis has increased in the more recent studies, and so the overall risk is dragged down. If stenosis didn't matter, you wouldn't look for that. So that was an example of where we got things wrong, and the prognosis in secondary prevention of patients with asymptomatic stenosis probably hasn't changed over the last 2 or 3 decades. Finally, cerebral small vessel disease and dementia. How is that looking in terms of burden? Well, smoking again is a risk factor, particularly for vascular dementia. Nearly all the patients I see with TIA and stroke have a degree at older ages, certainly, of vascular cognitive impairment. Some have dementia. Virtually everybody with peripheral vascular disease has some vascular cognitive impairment. So it's a common problem. And as far as we can see, the rates aren't going down. This is the most recent data we've got following up our patients after TIA and stroke. And there are very high rates of dementia up to 5 years follow-up, particularly after major stroke, but reasonably high rates after TIA and minor stroke. And so although, again, the age-specific incidence is coming down a little, the number of people reaching their ages and having those events is going up. So the burden of vascular dementia is still increasing. So just in conclusion, reduced rates of smoking and the widespread use of statins will certainly have an impact on the burden of vascular disease, but the numbers of patients that we need to see, I think, will continue to increase because of the aging population, inadequate control of blood pressure, inadequate uptake of anticoagulants for AF, and increasing obesity and diabetes, as we're about to hear. And also, most worryingly, the recent reversal in the previously falling incidence of some vascular diseases at younger ages, which I think could be a canary in the coal mine for a less bright future than we've all hoped for. Thank you very much.
Thank you very much. That's very sobering and a lot of food for thought. We now have a talk by Professor Jonathan Palabji. He's a consultant diabetologist at Imperial Healthcare. He established the first diabetic foot service within Imperial. He's the National Director for Diabetes and Obesity at NHS England, and is also leading a collaboration between NHS England and the Public Health England, the Healthier You Diabetes Prevention Programme. He's going to let us know about diabetes and its prevalence and how it's going to keep us all employed for the next 30 years. Thank you.
Thank you. Indeed, I will. Lovely to be here. Really grateful to Mike and the Vascular Society for inviting me along today, and how refreshing to be here in person at a conference. Fantastic. So my title today, Increasing Diabetes Prevalence and Its Impact on Vascular Surgery. I think that statement is apparent to all in the audience. We have seen greater and greater numbers of people with diabetes over recent years, and I'll go into the background of that. And it has an inevitable consequence on capacity within vascular surgery services. I'll talk a little bit about the pathophysiology of diabetic foot disease. I want to focus majorly on the changing population demographics, which maps a lot of what we've just heard in the last talk, actually. I want to talk a little bit about what we've done nationally to try and address the increasing prevalence. So I'll talk about the NHS Diabetes Prevention Programme. I'll talk about our treatment and care programme. But I also want to tag on at the end the impact on diabetes, but diabetes and COVID, and its impact on that changing population demographics, which I think is very important. Pathophysiology, the cardinal permissive complication of diabetes for the development of diabetic foot disease is, of course, peripheral neuropathy. That's a microvascular complication. The motor component of the neuropathy causes this clawing deformity of the feet. with much greater weight-bearing pressures at the metatarsal head areas, at the heels, and banging on the front of footwear, the tips of the toes. And the sensory component means that the brain doesn't get the alarm bells of pain when a lesion starts developing. And you can see this individual has already realized that risk with a neuropathic lesion over the plantar aspect of the left second metatarsal head area there. The microvascular complications are fairly ubiquitous. So when I'm sitting in my foot clinic, if I see a peripheral neuropathy such as this and pick up my ophthalmoscope, I would expect to see concurrent retinopathy. And if I don't see that, I'm thinking of a second hit that perhaps there's something else causing the peripheral neuropathy other than the diabetes. So that is the major permissive complication. But as this audience knows only too well, we then have a really important and variable contribution from peripheral vascular disease. Important to differentiate the major etiological factors. For microvascular complications, the major determinants are duration of diabetes and the exposure to hyperglycemia over that time. So it's, if you like, the area under the hyperglycemia curve over the duration of diabetes, whereas the major determinant of peripheral vascular disease is age. Diabetes almost certainly contributes to more rapid aging and a certain distribution of the peripheral vascular disease in terms of more diffuse distal disease, but age is the major determinant. That sets the background for what we're seeing and what we have seen over the last 3 decades or so in terms of the changing population demographics and characteristics. Now, this is a graph from the Health Survey for England, which collects data on a sample of the English population annually and goes back a good 25, 30 years now. So this shows you the inexorable increase in prevalence in men and women of obesity from 1993 through to 2018, so over a 25-year period. Now, I show this because 90 to 95% of all people with diabetes have type 2 diabetes. And the major modifiable risk factor for incidence of type 2 diabetes is indeed obesity. And so if we look at a different slide from the Health Survey for England study, this is from the 2019 study. This is adults with doctor-diagnosed diabetes, the vast majority of which is type 2 diabetes. Again, men and women in blue and grey, respectively, and what you see is an increase in prevalence of doctor-diagnosed diabetes from around 2% in 1994 to around 7% in 2019, just before the pandemic. So, as you can see, the substrate for your lower limb arterial vascular surgical services, a large proportion of that substrate population is the people with diabetes, and that is clearly increasing. Now, I am dwelling on the drive to increasing incidence, but as we've heard in the last talk, there is another component to that, and that is the remarkable gains in health at population level, really, and certainly even greater in the diabetes population over the last 20 years or so. Now, this slide and the next are from a paper published earlier this year in the Lancet Diabetes and Endocrinology, showing, so this is cause-specific mortality rate in people with diabetes. This is taken from the CPRD data set. The top 2 lines are men and women mortality from heart attacks, and the lower 2 lines are men and women mortality from stroke. And one of the greatest gains, probably attributable to reduction in smoking rates, more statin use, more aggressive management of hypertension and hyperglycemia in our diabetes population. But we've seen reduction in event rate in the diabetes population quite dramatically. So this is from the turn of the millennium, when almost half of all deaths were attributable to cardiovascular events, and that has diminished considerably. So I'm painting a picture of increasing prevalence of diabetes driven by the increasing prevalence of obesity nationally and globally. But on the flip side, we're seeing increased longevity of our population with diabetes, which is a great success of the last 20 years of healthcare, due to the reduction of cardiovascular events. And that's illustrated from the same paper, actually, in a different way. This is the proportional contribution to mortality burden of leading cause-specific diseases in those with diabetes over the same time frame. And the blue stuff is cardiovascular disease. The darker blue is ischemic heart disease. Under that is stroke. And underneath that is other cardiovascular disease. So the blue portion of that diagram has gone from almost half back at around 2001 time to a much lower proportion, such as the commonest contributor to mortality now in the diabetes population is actually cancers. So that, I hope, plants the picture of the increasing pool of the substrate population who can develop diabetic foot disease and who may go on to rely on your lower limb vascular surgical services to treat their diabetic foot disease. Now, I've articulated the changes in population demographics, which I see every day in my own multidisciplinary diabetic foot clinic. I had the opportunity to write an editorial in the BMJ just before the pandemic and articulated my views on the demographic changes. But if I look at my own service, I set up over 20 years ago on the St Mary's site at Imperial. I've been fortunate to work with fantastic vascular surgeons over that time. I set up initially with Nick Cheshire. I've worked with Rick Gibbs, Colin Bicknell, and latterly Joe Shaloub. I've been hugely fortunate. But over those 20 years or so, there's been a dramatic change in the characteristics of the patients coming through the service. In the early years, we were seeing younger people with predominantly neuropathic foot disease. And that's much easier to treat. You offload, you treat antibiotics as necessary, attention to detail with wound care, and the vast, vast majority will heal. Roll the clock forward 20 years, those individuals from 20 years ago were then going on and having their index cardiovascular event at relatively young ages and were either dying of, well, far more likely to die of that index cardiovascular event. Rolling the clock forward 20 years, those same individuals are either not having that index cardiovascular event at all, or if they are, they're surviving it. And that means that the average age in our multidisciplinary foot service is higher. As I've mentioned in an earlier slide, age is the major determinant sitting behind peripheral vascular disease. So a much greater proportion of our workload in the foot services constitute older people with a much greater contribution to non-healing from peripheral vascular disease, but also multiple long-term conditions, multimorbidity. So those same individuals are much more likely to have cognitive impairment, to have impaired renal function, and often to have heart failure, which again is a challenge and compromises our ability to achieve healing. So a real shift in the population characteristics, I would say. What are we doing about all of this? Well, I've been in post as National Clinical Director for Diabetes and Obesity now for over 8 years at NHS England. One of our stated aims in the policy document from NHS England that we published in the latter part of 2014 was that England would become the first country internationally to implement at scale an evidence-based type 2 diabetes prevention program, so tackling that inexorable increase in incidence that I referred to in the earlier slides. Now, we have really high-quality data from high-quality randomized controlled trials across a number of continents showing that if you take people with pre-diabetes and you support them through behavioral change around losing weight and exercising more and improving the quality of nutrition, you can reduce the incidence of type 2 diabetes in the trials, cumulative incidence reduction of up to 60%. And so we endeavoured to implement such a programme nationally in England. First year of national rollout of the programme was the 16-17 financial year, by the end of which we achieved just over 50% geographical coverage of England with that programme. By the end of the following financial year, we hit 75% coverage. And by the summer of 18, we did become the first country internationally to achieve ubiquitous coverage across the country with a type 2 diabetes prevention programme. That coincided with the 70th birthday of the NHS, which made for quite an attractive narrative and saw me on the telly a couple of times, which was quite nice. But the programme has gone well. We are now about to reach the 1 million milestone in terms of numbers of people referred into the programme. We'll cross that threshold in the next few months. This was a paper we published in Diabetes Care a couple of years ago on the first 250,000 or so referrals into programme, and the weight loss trajectories and the HbA1c reduction trajectories, and this is in the pre-diabetes population, are bang on course with what one might have hoped, looking at the impacts of the clinical trials reported, such that we might expect somewhere in the region, and we should have data on this in the next 12 months or so, somewhere in the region of a 25% reduction in type 2 diabetes incidence, looking at the weight loss trajectories that we're achieving so far. We also have been supporting a diabetes treatment and care programme, given the burden of morbidity in those with diabetes, such a high proportion of the population, and also the huge cost to the NHS. And we were able to seek funding through the Treasury's comprehensive spending reviews in 2015 and various milestones when funding became available for the health service. And we now have quite an extensive treatment and care programme. One of the facets of that programme is to improve access for those who need it to multidisciplinary diabetic foot care teams up and down the country. This slide just shows the proportion of hospital sites and trusts that do not have access to that multidisciplinary diabetic foot care, which was around 40% in 2010, and by 2019, prior to the pandemic, was less than 20%. We continue to invest in better access to those services. This is the entirety of the treatment and care programme, which amounts to around 120 million investment over the last 5 years. But in the red box there is the investment per annum on increasing access to those multidisciplinary diabetic foot care teams, and that amounts to around a 40 million investment over the last 5 years now. We're often judged, aren't we, by major amputation incidents as the ultimate outcome from diabetic foot disease. These are the rates across England over the last decade or so. So this is major amputation rate per 10,000 people with diabetes, which is a common way of expressing this outcome, and you can see a drop in incidence in the first half of the decade, which has subsequently plateaued at 8.2 per 10,000 people with diabetes, but that compares highly favourably actually to internationally, but does mask quite a marked variation across the country. Now, I've painted a picture of increasing rates of obesity over 25 years or so, driving increasing incidence of type 2 diabetes and increasing longevity, increasing the pool of people with diabetes who can then present to your vascular surgical services. Obviously, the world has changed hugely, and often with tragic consequences, unfortunately, for the diabetes community since onset of COVID 20 months ago. Now, 1/3 of all deaths across the country have been in people with diabetes. We have been blessed over a number of years with fantastic data in diabetes across England. So the National Diabetes Audit has been running for 18 years or so. It now is a fully comprehensive register of everyone with a code of diabetes across the country. And we have been able to disentangle a number of the unknowns during these last 20 months around COVID by linking the National Diabetes Audit data set with COVID deaths data sets, etc. This is I've put up the wrong paper, apologies, but we have a series of around 5 papers in the last 18 months in Lancet Diabetes and Endocrinology describing COVID within the diabetes population in England. The first 2 appeared as paired publications in Lancet Diabetes and Endocrinology. We managed to publish them in the first wave using that enormous potential of data and data linkage to show quite precisely the absolute and relative risks of death from COVID in those with diabetes. We were also able to very clearly show strong associations of mortality, COVID mortality, with HbA1c values and with body mass indices. So certainly diabetes, and we know independently obesity have been major independent risk factors from the more severe outcomes associated with COVID. But there's a bidirectionality here, and this is another piece that we published this summer, actually, in Lancet D&E, which is our baseline weight data from the National Type 2 Diabetes Prevention Programme. Each dot is the mean weight per month of participants starting the programme. The error bars are 95% confidence intervals, starting from April of 17 through to March of 21. And you can see the first 200,000 odd initial attendees attended before the pandemic, and then we had quite a rapid rise in the baseline weight coincident with the first lockdown, and these are 50,000 odd people who have started the programme following onset of the pandemic. So in a reverse way, the pandemic and its social consequences and lockdown have caused us as a population to gain weight. This is illustrative in the pre-diabetes population, but perhaps more frightening is data that many may have caught, picked up by all of the national newspapers on the 16th of November, so a couple of weeks ago. The National Child Measurement Programme annually puts children in state schools, all children in state schools, on scales and heights them at the ages of 5 and at the age of 11, so in reception in years 6 at primary school, and that has been concerning us for a number of years. And you see here the fairly constant but alarmingly high proportion of children, this is 5-year-olds, I think, who are obese or overweight. But look what happened in the COVID year. Just look, and that's the reason for showing this slide, this sudden and marked increase in prevalence of obesity. And that is problems for us in store, I think, for the future. So I've painted a picture of increasing incidence, us trying to tackle that with the National Type 2 Diabetes Prevention Programme, and then COVID superimposing with higher rates of obesity. I've painted a picture of increasing longevity in diabetes, but that is compromised to some extent by the COVID pandemic in recent times, with a third of all deaths involving people with diabetes. So a complex picture, perhaps, but I think the conclusions of that is that the implications for vascular surgical services, lower limb services, in supporting our multidisciplinary diabetic foot services, those requirements have expanded over the years, and like the conclusion of the last talk, I don't think are going anywhere soon and will continue to expand. Just finally, a lot of noise in my inbox from a national perspective during COVID times that really major concern. We're seeing fall off in attendees in foot services, but we're seeing individuals crashing through the doors of A&E with more extreme presentations and more advanced presentations with diabetic foot disease going straight to amputation. In fact, that wasn't our experience at Imperial, and I wasn't convinced that that was necessarily the case across the country. So we looked, and again, this we again linked national data sets. So this is all minor and major amputations in people with diabetes across England. We published this in Diabetes Care about 6 months ago. So on the left is major amputations, on the right is minor. This is number of amputations per month, but the figures were very similar if you looked at rates. But this is number of amputations per month. The blue line is the average per month, taking an average of 2017, 18, 19, so the 3 years pre-pandemic. And the red line is the corresponding numbers per month in the first COVID year, 2020. And when we published in Diabetes Care, we had data up to the end of October. And to our surprise and somewhat relief, given that routine care, including foot checks in the community, has really fallen off during COVID times because of the workforce being occupied in other ways, obviously. But we actually, in the first wave, saw around a 6% reduction in major amputation, but a 22% reduction in minor amputation. Now, the major amputation fall-off was mainly in the most elderly, and we have to acknowledge that that may be because of the competing endpoint of death from COVID. But the minor amputation picture was very different, and we've seen a reduction in minor amputations across the age ranges. And we think that that probably is attributable to people with diabetes and peripheral neuropathy just being less ambulant during lockdown and during COVID times, and so less likely to ulcerate and need minor amputation. A few weeks ago, we updated this analysis. We haven't published the updated analysis yet, but this just takes your red line for 2020 to the end of that year, and the green line is now now 2021, and the referees of our paper were very keen to know what would happen subsequently, and some speculated that we would see a subsequent rebound and catch up for the amputations that we may have missed. But we don't see a rebound, in fact, and this is data right up to this summer, which is somewhat reassuring. So I'm going to stop there. Thank you very much for your attention. I think the conclusion is that lots of work and revascularization and impact for your vascular surgical services through our diabetes populations and through our multidisciplinary diabetic foot clinics. And thank you very much for your support with that. I'll stop there.
Yeah, John, there's plenty of work to do. I'm now going to ask Chris Imray, past president of this society and chair of the workforce committee on the Vascular Society, to tell us, have we got the workforce to do it? Chris, thanks very much.
Thank you very much indeed. It's fantastic to see you all face to face. We had a year last year when we didn't get to meet, and we did our best online, but it's, as I say, a vast improvement seeing everyone here. Background disclosures: I'm a vascular and renal transplant surgeon. I have clinical academic time as well, and I'm also the outgoing chair of the Vascular Society Workforce Committee. That particular committee we set up at the beginning of 2019 to try to address some of and pull together some of the issues that we do see in the vascular workforce. Trying to predict the future is not easy, and we've heard a certain amount about the demographics of our patients and what's going on. I'm going to talk a little bit about the demographics of the workforce, and Lord Darcy also talked about technologies and pharmaceuticals. Trying to predict the future, as I say, is risky, and I think I would take anything that is said here with a degree of caution. What we do know, and it's come through in a couple of the talks, is our population is quite clearly ageing, and it's ageing fairly fast, and with that comes a higher disease burden. And just a couple of slides just confirming what we've already heard, that there's an escalating global burden of serious health-related suffering. If we look at this particular one, there's a rise both in cerebrovascular disease and also peripheral vascular disease, somewhere around the 35% on a global basis by 2060. And the number of people that have got serious illness and are likely to be ill for a long time before they die is also increasing. So the first dates there are 2016, and the last ones are predicted out to 2060. So again, we're getting a population with a greater proportion of our population with long-term chronic disease. And this is all occurring in the older age group, as we've heard before. So let's be a bit more specific about the vascular population. This is a paper that was published in 2013, but does look at the issues. What it shows is the ageing population is a primary driver, and that demand for vascular surgery has the highest predicted group amongst all the others, so that's including cardiology and care for the elderly, at a 31% increase. So then let's try to transfer that onto our workforce and see how that works. Dennis Harkin led the third iteration of the VS Workforce Survey in 2021, the first being done in 2013, in this particular study he was looking both at the workforce but also an element of burnout and resilience, because this was in the middle of the pandemic. And what it shows, if you look at the top line there, it's slightly confusing in that it's in reverse date order. So we've got 2013 is over on the right-hand side, and 2021, the most up-to-date, is over on the left-hand side. But what you can see is that there is a modest increase in the number of surgeons, but because of the change in population demographics, we're actually seeing a reduction through most of the UK in terms of the number of surgeons per head of population. And the Vascular Society would suggest we need somewhere around one vascular surgeon per 100,000 of population. Nowhere do we get near that. And if you look at the Northern Ireland figures, there's actually one per 236,000 now, which is really quite an alarming trend. If we look at the number of consultants that are needed, we can see that, again, we are looking for a substantial increase. In England, it's 26% increase, Scotland 36%, and Northern Ireland would require 125% increase. And we're a long way off that. There are regional variations, and again, if you look at these figures here, you can see that the southeast is the least well provided for in terms of England, in terms of population per surgeons per population at 1 per 171,000, so dramatically down on the sort of figures we're looking at. And yet in other parts of the country, particularly somewhere like Yorkshire and Humber, it's actually not too bad at 1 per 118,000. So if you look at the expansion that's required, both in terms of the consultants and the trainees, it's quite a marked rise. And I won't go through all those figures, but again, there should be regional distribution of that increase in those increased numbers if we're going to address the apparent disparities. There's a change in the workforce over the years between 2013, when the first study was done, to now. We've seen roughly a doubling in the proportion of female consultants compared to 2013. And if we then look at the new consultants being appointed, it's roughly 1/3, and vascular surgeons in training slightly, again, around 1/3, slightly higher figures. So we're seeing a gradual trend to reflect society more closely. If we look at workforce diversity, again, the green figures there reflect a white ethnicity, and all the other groups are then you can see, make up about 40% there. What it does conclude is that 29% of all consultant vascular surgeons in the UK are currently working were born outside the UK. And again, there's a significant degree of diversity within our consultant population. The next slide really begins to look at how we might begin to address the problem. And we are vascular surgeons, so it seemed entirely appropriate that we talked about simple principles here: inflow, conduit, and outflow, which we're all very familiar with when we're trying to run grafts, for instance. And what we need to do is think how we can increase the number of individuals entering the potential vascular workforce. So we need to encourage medical students and junior doctors. And I'm delighted that the Rouleau Club has now got membership, I believe, of just over 1,000, which suggests they're doing an excellent job in trying to encourage and enthuse medical students and junior doctors to get involved in what I believe is a great specialty. We need to look at the number of training posts, which has remained remarkably static for a long period of time. And one of the big issues here is how do we increase those numbers? And it's one of the issues we were talking about at the committee meeting yesterday. The other thing is to bring in the non-training posts, and I'm not very comfortable with that name, but I think we need to use a phrase that we all understand. So those individuals have chosen not to, for various reasons, go into a formal training post. We need to encourage them and facilitate a way by which they may be able to complete the training if it's appropriate and become a consultant, going through the CSER route, for instance. We then need to look at the actual workforce we've got. We've had a year and a half of really intense and hard work, and the danger is that there is a significant degree of burnout and wariness amongst the workforce. We need to think more positively and more proactively about how we can get that work-life balance correct, and also how we can look at less than full-time working amongst our consultant population. And so one begins to think about individualizing the job plan for a specific consultant to make sure that they feel that they are being valued and able to work to their best. Because if we just work people harder and harder, we're not going to get the best out of them. And then finally, at the end of the, or towards the end of one's career, there's a huge amount of concern of early retirement. There are a number of factors that are occurring both within hospitals, but particularly about what's happening on a national basis and things like the pension arrangements. And I think these sort of things do need to be thought about. We also need to work out how we can use our more experienced surgeons in a better way in terms of mentoring and teaching. It is unrealistic to expect the older surgeon to be able to work at the same intensity that a younger surgeon is, but they may be able to do certain things in a better way. And then I did mention renal transplant surgery, there's also another component that we need to put into this, and that is how do we, if you look at the tubules there, you can see secretion of into the tubules and the production of urine. We need to work out what other members of the workforce could help. We need to think about our vascular nurse specialists, and we need to expand those, but also think about operating assistants, surgical care practitioners, etc. So from the 21 workforce survey, what we've got is increased gender diversity. Race and ethnicity diversity is greater, in fact, than the general population. Many surgeons have significant additional roles which have huge value, but not necessarily to the trusts. We need to look at what we're doing with our more experienced surgeons, and we need to think about burnout. And then something else that came out of this was the harassment and bullying. And I think that's something else that we really do need to address. I don't know how many of you actually picked up your POVS document. This is an absolutely superb document that Sophie Renton and Marcus Brooks led on, looking at all sorts of aspects of provision of vascular services. But in particular, there is now a section specifically on workforce. And I think one of the things we haven't in the past thought about is the concept of the vascular team. And I'm not going to go through all the components of it, but it is much, much larger than just the vascular surgeon. And actually the way in which we work has changed dramatically. We've gone from a individual-led procedure-based service to a team-led service. And we need to change the way we think and deliver that. And this is the photograph within the POVS document from the Bristol Bath Western Vascular Network, but it does show how many people are involved. It's not just Marcus at the front there, it's a whole team of people around him. We need to look after our staff, and one of the things that, on having done a number of Royal College inspections, looking at units that are in trouble, is that one of what I perceive to be the canaries in the mine of a unit is how well the MDT works. And a well-motivated, cohesive and organised team is the unit's greatest asset. And when those of you who are looking at jobs and thinking about where you might want to work, you need to consider that carefully. It's not just the geography, it's whether or not you've got a good team that you're going into. And then finally, again, within the document is a comment about zero tolerance and undermine for bullying, and we'll be talking more about that at another stage. So in conclusion, the demographic healthcare time bomb, we've heard a lot about that. The workforce is already challenged on a number of fronts. We need to improve and increase recruitment to training. We need to look after the existing workforce and reduce early retirement. We need to think how the delivery of care can be improved by using other people. But I think the other thing we need to do is to understand and celebrate the vascular team. And I was very lucky to cycle along the Outer Hebridean Way only a few weeks ago with a great team, representatives from all the subspecialties. And I think that is, to me, an exemplar of how team working could be. I'll finish there. Thank you very much indeed.
Chris, thanks very much. My pleasure now is to introduce Dr. Lian Armitage. I first met Lian when she was speaking at a school my sons went to. Lian is the co-founder of the Armitage Foundation and is going to talk to us about creating a medical workforce that reflects a diverse society. You're really welcome, Lian. Thank you.
Thank you for the introduction, Mr. Jenkins. Good afternoon, everybody. In my presentation today, I'm going to be talking about the importance of creating a medical workforce which reflects the diverse society that it serves. And when I use the term medical workforce, I'm not only referring to those working at the ground level, but to those working at every single level, including those working at the board level, helping to map out the strategic direction of individual hospitals and the NHS as a whole. Now, I'm going to start by sharing my story with you just to help you understand why I'm so passionate about the topic of diversity, and also to put into context some of the issues that I'll discuss throughout my presentation. So this is a picture of me when I was 15 years old. People often say that I don't look that much different, which I'll gladly take. When I was 15 years old, I decided that I wanted to become a trauma surgeon. And there is a backstory to this, which I'll share with you. I was coming home one day with my sister, and I remember hearing the propellers of a helicopter as it was making its descent towards a huge grass field in the middle of a big estate close to where I was living. And anybody who knows me well knows that I absolutely love helicopters. So I got really excited, and I managed to convince my sister to walk with me to where the helicopter was landing. And when we arrived, I remember seeing a group of people gathered around, and everybody was just standing there with blank faces. And immediately I knew that something wasn't quite right, because their facial expressions did not match the excitement that I was feeling inside. So I turned to the closest person in the crowd, and I asked her, why is everybody gathered here? What's happened? And her response drained all excitement from me as she told me that a young man had been stabbed. And growing up in Peckham in southeast London, unfortunately, it wasn't uncommon to hear of young men losing their lives because of gunshot wounds or stab wounds. But there was something about this incident that really hit me deeply. And I think it's because I went from that state of being so excited because a helicopter was landing to then realizing that, oh my God, this helicopter hasn't landed for any good reason at all, but rather because a young man is potentially fighting for his life. In that moment, I remember feeling so many different types of emotions. I felt a sense of anger as I looked around thinking, everybody's just standing here staring, but who's actually going to do something to make a difference? I then remember feeling a sense of disempowerment as I thought, what can I do? I'm just a 15-year-old girl. So that evening, I went home with a heavy heart, and I went straight to my room where I just sat down and meditated and prayed and asked God, what can I do to make a difference? And then the idea came to me that if I aspire to become a trauma surgeon, that would give me a platform to go into environments where young men are involved in knife and gun crime in the hope of inspiring them to be and to do better. Now, when I shared this story with my clinical supervisor, he said, Lian, in order to help the audience make the link between Peckham, you must show them a picture of Rodney and Delboy from Only Fools and Horses. Now, if I'm honest, I didn't actually know who Rodney and Delboy were, and I told him this. And he said, if any of you in the crowd are as old as he is, then you'll definitely know who Rodney and Delboy are. And for those of you in the crowd that are younger, Peckham is now the cool place to live thanks to gentrification. Now, to go back to my story, as I said, I made this decision that I wanted to become a trauma surgeon. However, I was coming from a very disadvantaged background. I grew up in a single-parent home on a council estate in Peckham. I only met my biological father for the first time when I was 19 years old. Out of my mother's 5 children, only one other went to university, so going to university wasn't really the culture in my family. And my mother wasn't educated past GCSE level. She didn't actually leave secondary school with any qualifications, so she didn't really understand how to navigate the higher education system. And there were no doctors in my family or in my social network that could show me the ropes. So I went to Google, as you do, and I did a search. I followed the steps, and now I'm a doctor. But the reality is there are several other students coming from a similar background to my own who are not as fortunate as I am. And to help you appreciate the scale of this issue, the British Medical Association published a report called The Right Mix, which highlights that across the UK, half of the schools do not produce a single medical applicant. And these tend to be the schools that are populated by students who are coming from low socioeconomic backgrounds and certain ethnic minorities. And I came across this statistic in my second year of medical school, and I remember being completely shocked by it. And coming from the background that I come from, I felt like I had special insight into many of the challenges and the obstacles that these students were facing. So in my third year of medical school, I decided to co-found a charity called the Armitage Foundation, which is a charity that's committed to increasing diversity across UK medical schools. And what we do at the Armitage Foundation is we provide programs. Pre-COVID, these would be programs where we'd go into schools and they'd be part practical and part theoretical. And the programs are designed to inspire the students, to equip them, and to give them a holistic understanding of what it means to become a doctor, as well as the confidence to know that they can do it. And at the Armitage Foundation, we believe in a long-term continuous intervention approach. And this is really important because at present, most medical schools have widening participation departments where they'll offer single-day courses or one-week programs. And these are great at sowing a seed of inspiration, but they don't really, or they're not really able to cultivate and develop that seed, because really these kind of students that we are supporting, they're lagging behind their wealthier peers in so many different areas, and a long-term continuous intervention is one that will be able to support them at all of the crucial stages where they need support. And that's why at the Armitage Foundation, we're working on a 3-tier program which will support students from year 8 all the way up until their application to medical school. As a result of the work I've been doing through my foundation, in 2018 I was awarded the UK Queen's Young Leaders Award by Her Majesty the Queen at Buckingham Palace, which was an absolutely incredible experience. And as a result of the award, it's really helped to further the work of the charity, which I'm really grateful for. Now, this issue of diversity is one that extends beyond medical schools. The British Medical Journal produced an article which highlighted that doctors with English names were twice as likely to be shortlisted for senior house officer jobs compared to those with Asian names. And I've also heard anecdotal examples from consultants who would say when they changed their surname to say the English surname of their partner, then they were shortlisted for interviews and then they were able to get the jobs that they wanted. So this really is an issue. There's also a class pay gap. Doctors from less privileged backgrounds earn approximately £10,000 less than doctors who are coming from more wealthier backgrounds. And there's also a lack of diversity at the leadership level, and this is most notable in London. 40% of the population in London is from a black and minority ethnic background. 43% of the NHS workforce in London is from a black and minority ethnic background. Yet at the board level, only 14% of positions are held by people from a black and minority ethnic background. And it's really important that we have diversity at the leadership level, because if everybody is coming from the same kind of background, their insight, their perspectives, the paradigms through which they view things is going to be skewed by that background. But when you've got people coming from all different types of backgrounds, they're able to offer different insights, different perspectives, help you to consider different issues, and ultimately that will mean that the decisions that are being made will be better reflective of the population, and that will help to ultimately improve health outcomes for patients. There are potentially harmful consequences of a lack of diversity, such as unconscious bias, differential health outcomes, and in the worst case scenario, death. And I think COVID-19 is quite a good example of this. The BMA published an article earlier this year which highlighted that 95% of the doctors who died from COVID were from a black and minority ethnic background, even though only 44% of medical staff are coming from a black and minority ethnic background. And when they accounted for factors such as age, sex, region, and deprivation, doctors from a black and minority ethnic background still had a 10 to 50% increased likelihood of dying from COVID. And there were many factors which were suggested as contributing to this, such as doctors from black and minority ethnic backgrounds not feeling like they have adequate access to PPE, and also some of the actual PPE masks not being well suited to certain facial structures, such as in some cultures they wear beards. And I'm by no means trying to oversimplify a very complex and multifactorial issue here, but I do wonder if there was more diversity at leadership levels, maybe some of these factors might have been considered, and maybe some of these deaths might have been averted. The Royal College of Surgeons also published an independent review on diversity and inclusion in March of this year. If you haven't already read the document, I really encourage you to do so, because it's a really interesting read. And I've taken an extract here, which is an anecdotal example of what I think is a really good demonstration of unconscious bias. It's a surgical trainee who is in a clinic with a consultant, and the consultant sees two babies, both from different ethnic backgrounds. One is an English baby and the other is a Turkish baby. Both babies have identical diagnoses which will require the same management plan, but the consultant says for the English baby he'll see them in his clinic the following week and he will himself perform the management plan. But for the Turkish baby, they'd be put on a waiting list for 3 to 4 months. And the trainee here is saying that despite the consultant being very respectful and very gentle with both babies, he didn't seem to value both in the same way based on the management plans that he offered. And I don't think the consultant would have been consciously aware of what he was doing, because that is what unconscious bias is. You're not aware that you're doing it. But when you do have more diversity in teams, they can help you to recognize different things or call out different things, which can help you to become more aware of some of these unconscious biases, because the reality is we all have unconscious bias. I love this quote by Malcolm Forbes, which summarizes the power of diversity as the art of thinking independently together. Now, I know that a lot of what I've discussed covers some quite sensitive and potentially uncomfortable topics here, but I want to empower everybody in the audience to know that you can do something to make a difference. You can contribute to positive change. I want to encourage you to just reflect. You know, sometimes being real and honest can be a little bit uncomfortable, but we have to reflect in order to question, have I walked in unconscious bias, or am I doing any of these things? I want to encourage you to be a champion of diversity. If you're in a team that you notice isn't really diverse, then call that out and encourage there to be better representation of, you know, the people that you're serving and the groups that you're working with. If you're involved in clinical trials, I want to encourage you to make sure that the people you're recruiting to those trials are representative of the population. And of course, if you're interested in the work of my foundation and you'd like to get involved, then you're more than welcome to come and speak to me afterwards. Thank you for listening.
Lian, amazing talk as expected and very topical and apt. We're going to pinch 5 minutes from coffee to have some questions. We've learned a lot, actually. We've learned that the population is aging, and despite all our treatments, there's still going to be a lot of disease to treat, but we probably haven't got the workforce to do it. I suppose on the up, we've got another 50% of schools we can recruit from, so that's going to be useful because we're going to need them. So I'll invite any questions from the audience, and we will finish at 5 past to have a proper coffee break. Professor Sayers.
Thank you very much. Rob Sayers, Leicester. Can I ask Professor Rothwell a question? It's sort of 3 questions in one, really, so forgive me. But I was interested in your comments on cognitive impairment in vascular patients, which seems to be getting worse, and it's a problem for all of us. So do you think there's evidence that that produces worse outcomes or surgical outcomes? If it does, should we be screening patients and trying to do something about it? And if they're cognitively impaired, how on earth do you sort of consent them or enter into shared decision making when it's difficult to, you know, make them understand what we're talking about in the first place?
Yeah,
Apologies.
it's a series of very good questions. In fact, pity my wife isn't here because she's a geriatrician who spent the last 10 years trying to look into this in Oxford. And in fact, she finds that surgeons are far, far better than the physicians in terms of doing cognitive assessments and thinking about those sorts of issues. I think it probably does affect outcomes. Certainly after stroke, the outcome is much worse if you've got cognitive impairment to begin with. And I think you're probably just measuring a vulnerability of the brain. It's certainly the same with coronary artery bypass grafting, for example, as well. So I think that is an issue, and it's difficult to know what you can do to prevent that. I guess it does have some implications for consent. I think for consent, it's much less of an issue than people worry about it being, in the sense that the systems are very clearly in place for what to do in terms of consenting people with cognitive problems, and that shouldn't put us off. But I think it's helpful in terms of reducing complaints. It's a major problem sometimes when the physician or the surgeon has no idea that Mrs. Smith is demented until the family come in and mention the fact and make a complaint. So I think it is an important issue, but I don't think there are easy solutions in terms of outcome.
Mr. Chetta.
Lian, fantastic inspirational talk. I just want to ask you a bit more about your foundation. Numbers, and whether there's progress from juniors to seniors to scholars, and national distribution. Are there any areas that you'd like to target that currently are underrepresented in your foundation?
So at present, we're working in London and also Kent, but definitely we want to spread further out. In terms of how many that we're working with, so at the moment so the model that we have is we like to partner with the university first and then serve the schools in that local area, just because our volunteers are mainly coming from medical schools. So far we've partnered with St. George's, which is where I graduated from, and also King's College London, and we're serving the students around there. And we've also kind of done a joint partnership between King's College London and Medway Hospital to serve some of the students in Kent, because they've got quite high areas of deprivation there. And actually some of their schools don't even offer, say, the A levels for students to be able to even apply to medical school. So there's lots of structural barriers as well. But ultimately, yeah, we're trying to target areas of deprivation, areas where there's really a need, and to partner with universities first and then serve the schools around there.
I work in East Yorkshire and Hull, which is one of the most deprived areas in the UK. If you're interested in getting into the University of Hull or Hull York Medical School, I'd be more than happy
Yeah,
to.
that would be great. We should connect afterwards.
Paddy Coughlin.
Lian, yeah, can I back at what Ian said there? I'm interested it stops at 18.
Yeah.
And speaking to medical students, I know that there are continued issues within university, within medical schools. So as a society, what do you think that we can do to try and engage with students who are struggling there and perhaps offer the hand of the vascular surgeon to get people, we want to get people into vascular surgeries. So how do you think we can go about that?
Yeah, I think that's a really good point you make, because there is differential attainment gaps at medical school and even training thereafter. I think definitely making your presence more visible in medical schools, because while I was at medical school, for example, apart from maybe like a 2-week placement or 3 weeks on vascular surgery, I didn't really have much engagement. And also during training, I think it's really important that you maybe have mentorship programs and other things available so that the surgical trainees that maybe feel like they're struggling to get the support to progress their career can really feel like they've got somewhere to go to get that help.
So I tried to convince Lian to move from trauma to vascular, but she's actually got far too much important work to manage that at all. Abuon.
Thank you. Great session, great talks. I would like to ask Professor Emery about what can be done to retain more experienced colleagues who are thinking about retiring and so on, and what in practice can be done to try to retain experienced. You mentioned about perhaps different slightly modified roles, slightly modified job plans and so on. So I wonder if you can comment further on this.
That's a really important question, and I think what we're seeing is the result of not doing anything. And so therefore, whatever we do, I hope will start to improve it. I do think there are national issues, and certainly the one that seems to have the most noise is the issues around pensions, and I think that it would be really helpful if the government could set about doing that. I don't think that's something that the Vascular Society will be able to do on its own. It's the sort of thing that we need to lobby with the FSSA and other groups to try to get that through. I think having a frank discussion with your clinical director and trying to come up with a more personalised job plan is a good one. I have to say, though, I'm still on 2 acute rotas myself at the age of 62, and I was whinging about this as I cycled down the Hebridean Way. I can't get my clinical director to agree what I would like to do, so I can see that others might find it an issue. I think there's anecdotal evidence that you need to be a little cautious about retiring and returning, because senior surgeons are quite expensive, and I think what they would think there is a tree somewhere out there that is growing young surgeons that will do all the work that the senior surgeon doesn't do. So I think it's a question of following what you're good at. So if you're a teacher or a researcher, you should try and do more of that, and you should try to personalise it. And I hope that the Workforce Committee will start to come forward with some slightly more practical solutions that we can perhaps even work on some sort of document for the more senior surgeon.
Thank you. Thank you.
I'd like to just comment on that, because certainly during my time at the college, one of the things that we tried to do was to make it clear to people that retirement wasn't necessarily an option, but actually that if you could ask or make it possible for senior surgeons to work part-time, rather than take early retirement, and give them those roles such as mentorship, support, being a second-hand assistant in theatre, these sort of things, I think you could actually keep the workforce going. What burns out, and what, I was going to use a nasty word, but what absolutely upsets a whole lot of senior consultants is the fact that they're expected to do the on-call rota till the day they actually retire. And I think it's these sort of things that we've got to work on, and that's in our own hands rather than necessarily the management.
We've got a question from the microphone on the other side.
Thank you very much. A couple of questions for the panel in general. My name is Mohammed. I'm a consultant surgeon at Medway Hospital. So I'd like to meet you one day if you come to Medway. With regard to diabetes, Professor, you said that the number of major and minor amputations is generally on the downward trend. But in my hospital, which serves a very, very deprived area with real problems in social care and primary care, we're noticing the opposite. I don't know if a lot of the data that you've produced, you've looked into deprived areas and seeing maybe that might have an influence, because we are certainly, what I'm seeing is not what you're describing.
All I showed there was the national data set, and I hope I think I might have mentioned that there's huge variation around that. And when that has been looked at, I think we published a piece in the Lancet in about 2017. There's quite marked variation up and down the country. It was exactly the point that you're making, I think. I think the variation was something like 7-fold, so huge. Yes, I mean, the national stat on major has plateaued. But as you rightly point out, deprivation is a major factor. Ethnicity is interesting. It is a major factor. But actually, and as is sex, but diabetic foot disease and the amputation consequences mainly affect white men, interestingly. So we see significantly lower amputation rates in South Asian, African, Caribbean populations, interestingly, and we don't know why that is. And that's even when you regress out every possible determinant, including height, which determines risk of peripheral neuropathy. But, you know, it's not fully understood why that is. But, you know, you make an excellent point. Fully appreciate that. My data was a simple summary slide for the whole country.
No, if I can just make one very brief point about diversity. You mentioned difficulties in ethnic minority doctors getting to senior practices, and I certainly experienced that myself, and I certainly know of a couple of colleagues who had to change their surnames as well. And I was Lord Ribero's registrar and medical student. It was because of you, sir, that I persisted with my career. Thank you.
So we'll go to the 3 questions here, starting with Keith Jones.
Thank you very much. And Mike, thanks for a fantastic session. A question is to Chris and Lord Ribeiro, really. Related to functional capacity of the workforce, is there any indication what is the functioning capacity over which, if you go over that adverse events and outcomes will occur and will occur more often? I was just wondering if there's any evidence to show that.
Only to say that if you remember, only to say if you remember in the Francis report of Miss Staffordshire, he identified that the main problem was about falling workforce, and that incidents of harm tend to occur when you have a low workforce going forward. So I think that all the specialty associations in the past have made projections of what they think is the ideal numbers for their particular specialty. And I think we should be pushing that much harder to government, that if you want safe care, these are the optimal numbers that you need on a firm, whether it be a vascular one, a colorectal one, or whatever it is.
I fully agree with that. I think one of the other things that concerns me is the way the team functions. One of the problems when you come in to do a rupture in the middle of the night is you've got to assemble a team from scratch, and you've got to do it quickly. If you have people that are experienced, it's much easier to pull a team together and you'll deliver better results. I think that if the teams aren't as strong as they could be, that adds further problems. The individual has problems with bandwidth. They're trying to think of too many things at once, and I'm sure that has adverse outcomes. So I'd go with the numbers, which we've set at 1 per 100,000, and we should still be aiming to go for that. The evidence or the basis on which that number came is not quite as strong as it could be, but I don't think we should shift too far from it.
Agree. Professor Loftus.
Well, Chris, linked to what you just said about ruptured aneurysms, I mean, vascular disease we've seen is changing dramatically and will continue to do so, but we're still training people to be general vascular surgeons. I wonder, looking at the projections you've shown, whether we should be fundamentally rethinking how we provide vascular services in the UK, and if so, how we train people to work in that different kind of service. Aorta is the obvious example you've just touched on. Should that be super centralized, and should we be training aortic specialists to run a service?
I think that's a really important question, and if you also look at the reducing numbers of, for instance, carotids being done by individuals and units, we are needing to rethink that. Volume outcome measures are a serious issue. If you start to drop too far, then the team isn't as experienced as they could be. The disadvantages are further reconfiguration, and we know that that has huge challenges for a workforce and how a team functions. So I think one would need to think very carefully about the pros and cons about reconfiguring again and be quite clear that the intended benefit was greater than it was. I mean, the centralization to arterial hubs has already theoretically brought those teams together, but as you say, the numbers going down may weaken that.
Last question, Owen Famani.
Thank you. Thanks for bringing in the carotid debate, because that's my question to Professor Rothwell. I was very interested in your comments about the asymptomatic carotid disease. Asymptomatic carotid practice in Britain is now vanishingly rare. It comprises of less than 5% of the carotid endarterectomy patients that we treat. And in a comparable registry in Sweden, it's even lower. So what would you suggest is the way we actually approach asymptomatic carotid disease? Because I'm not sure surgery is the right answer.
Yeah. No, I agree. It's always fascinating when you look at regional variation, isn't it? And then the American registry is, I think, 95% of endarterectomies in the New York region are for asymptomatics, which perhaps has different drivers, as we all know. But you know, that sort of variation means obviously everybody can't be right, and I don't think 1% is probably right either. And I think the problem is that we're not very good at risk stratification. Obviously, you want to operate on those patients that are going to have a stroke. You don't want to operate on those that aren't and potentially harm them. And I think we're only now getting to the stage where, with imaging, better imaging, and better risk models, we can begin to target the smaller proportion of patients that are at high risk of stroke. But I think it's still very inexact. But we do need to do more work in that area. But I suspect we should be operating probably on 10, 15, 20% of patients if we knew who they were. But I think knowing who they are is the problem still.
So I'm going to bring the session to a close. Apologies we ran over. I'm blaming Darcy because he's not here. I'd like to thank all the speakers to try and bring together what the future holds for us. Before you leave, Louis wants to make an announcement about abstracts and prizes.
So, for those of you that have presented this morning in the sessions leading to the Sol Cohen Prize and the BJS Prize, you should get an email within the next hour and a half to let you know whether you've been selected to present in the prize sessions. And just to let everybody know that the presentations across the board today have been absolutely fantastic.
And the next session starts at 3:30 sharp. Thank you.